So yeah, let's just to get started straight. I want to talk about machine learning for evidence generation from electronic health records. This is the outline of today's talk. I'm going to start with a brief introduction, and then I'm going to talk about three typical problems or research topics when people leverage like real world electronic health records or claims, predictive modeling, causal inference, but here is really about how to balance the confoundings instead of discovery of causal structures. We also have work on that, but that is not going to be something I'm going to talk about today. And disease subphenotyping and some future directions. Let me start with some introductions. So I think everybody knows AI. Everybody has your own definition of AI, and machine learning is one way to achieve AI. And there are three basic paradigms of machine learning: supervised learning, unsupervised learning, and reinforcement learning. I don't want to explain them in detail for this audience. And deep learning, people are interested in AI, deep learning. I mean, deep learning is one particular type of machine learning, and people are all getting excited about machine learning in recent years. Is really because deep learning has achieved a lot of, oh yes, I see that message. So if you have questions, you can put it in the chat, or if you want to unmute and talk, that's also fine. So deep learning is one way of one particular type of machine learning, and recently, because of the various achievement of deep learning, people get excited about machine learning as well. Some examples such as AlphaGo, autonomous driving, voice recognition, and natural language processing. So people are thinking about, okay, so this is super powerful and very promising. So can they help with medicine and healthcare? So why people have that thought? Because with the development of computer technologies, hardware and software. So hardware, because we are capable of accumulating more different types of data over the years, and we also have the luxury of running, complex computations like using GPUs, and software is because you need all those apps or whatever applications that you want to capture those data and store the data and so on and so forth. So we got a lot of a diverse type of healthcare or medical data around the patients. I just listed some of the examples here. It's far from complete. So, and also there's everybody knows the notion of precision medicine, and when Francis Collins talking about precision medicine in this perspective, he specifically emphasized that we really want to integrate the information or the medical data from all different aspects, right? Not just the genomics or just the clinical data, but really from a microscope to macroscope, and even to the environmental factors, to more comprehensively understand people's health conditions precisely. So this clearly presented a lot of challenges to conventional computational technologies, such as a lot of hypothesis-driven technologies, because the data is becoming much more massive, large scale, and also heterogeneous. So that's why people think, okay, these deep learning models or machine learning models have demonstrated a lot of success in these other areas. So perhaps they can also be promising in medicine and healthcare as well. So that's a natural thought. So that's why we we see machine learning, the term machine learning in biomedicine more and more frequently in recent years. So I will particularly talk about some of the works from my lab. in the recent years, particularly on electronic health records or longitudinal patient clinical records. First, we talk about predictive modeling. I think I don't need to explain too much what is electronic health records, right? So every time when you pay a visit to a clinic, the doctors or nurses typing, ask you questions, doing checkups on you, and then typing all those information about you in his or her tablet or desktop, and the system behind that, capturing all those information, or the electronic health record system. It captures all kinds of information, you know, like lab tests, demographics, lab tests, diagnosis, medications, procedures, and also clinical notes, and so on and so forth. So if you pay pay visits to a clinic, not regularly, but to the same clinic every time, then over the time you're gonna have visit over visit. So it's really a longitudinal collection of the events within every visit for every patient. So that's why we already say that it's longitudinal. And of course, for different patients, you're going to have different behavior habits, like you need to do the checkup or the visits regularly, or most of the time, if you're healthy, we don't really pay visit regularly. And so that also brings in a lot of challenges for analyzing electronic health records, sparsity, and also the irregular temporal intervals and high dimensionality, because so much information is captured there, and so on and so forth. So there are lots of challenges analyzing electronic health records as well. So first, predictive modeling. I think this is most, I wouldn't say popular, but you see a lot of works on analysis of electronic health records about predictive modeling. I just want to show you one of the work we have done during the pandemic. That's just a collaboration between my team and our clinical laboratory and pathology department at New York Presbyterian Hospital at Weill Cornell. So it's in around the time of March, April 2020. So where New York City is at the peak of the first wave of COVID-19. And at that time, the medical resources super limited, not just in terms of like the number of beds or the number of doctors, but also in terms of the testing. So, and not like today, you've got all those fast kits. You have, if you want to do the PCR, you can do that. You just need to make an appointment. But at that time, because the resources limited, it's not everybody wants to do the test. You can get the test. It's really, you have to demonstrate certain symptoms, like fever, like cough, COVID-related symptoms before you can order a PCR test. And this is kind of like the principle of PCR test. I'm not an expert on this, but even until now, I think a PCR test is still used as the gold standard to confirm if a patient really have SARS-CoV-2 infection or no. I think at that time, there are some concerns from people about the potential high false negative rate of PCR tests. So what does false negative mean? Which means that although your test is negative, but you are not necessarily not infected. So perhaps you go back home, and after several days, you do another test, your result is becoming positive. And it is estimated the false negative rate could be as high as 30%. And if you think about back to like March, April 2020, that was pretty scary. That means that a lot of people, although they were let go home and testing negative, but still, he or she could be positive and become, contagious and, make this pandemic difficult to control. So then this is our paper, and then our Department of Laboratory Medicine, they're in charge of doing all these kind of testing. So they approached me. Number one is with this potential concern of this false negative, and number two is this PCR test, it takes time, and after you did the test, it takes at that time 1 or 2 days to get the results back, and this gonna further impact like how the patients are going to be managed, all these kind of issues. And remember, at that time, it's not everybody wants to get the test, can get the test. It's really the patient needs to already demonstrated some symptoms and signs, relevant symptoms and signs. So typically when they do the PCR test, they also gonna order some routine blood test, like the blood count, like the renal panel, hepatic panel, and also the inflammatory markers and these kind of things. So what they observe is that if the patient has actually got SARS-CoV-2 infected, there are also some abnormalities in their routine blood test as well. So they were asking, so is there any chance that we can kind of like build a predictive model? So based on the routine blood tests, so while we are interested in routine blood tests, because number one, they are cheap. Number two, they have a faster turnaround time. So not in terms of days, but really in terms of hours or minutes, you can get the results back. And of course, resource-wise, they are much less restricted compared to PCR at that time. So so what we do is this is a typical predictive modeling setup. I'm just introducing this as an example of what is the typical setup for predictive modeling in EHR. So let's say this patient is having a PCR test, and we go retrospectively and we look at within 2 days prior to this PCR test. So whatever routine blood test this patient has, and then we aggregate those routine blood tests into a profile, which is a vector. And if you may ask, what if the patient is taking multiple tests, multiple times of the same test? We just do some simple aggregation. We test it like min, max, average. It doesn't make too much difference in this case. And there are of course some missing values, and we did also tested some of the different imputation methods like mean, median, k-nearest neighbor, multiple imputation, and so on and so forth. And then, so in terms of model, nothing sophisticated. We didn't use like a fancy like deep learning model stuff or something. In this case, we tested a gradient boosting tree, random forest, lattice regression, and simple decision tree, and actually the gradient boosting tree and random forest can perform fairly well. This is, we are not saying this can replace PCR tests or something like that, but really this can serve as another evidence that we can report a score to make whoever the clinician is aware, so that if the PCR is a negative, is there a potential it could be a false negative or no? And actually we have done some investigation on that, and it turns out that our model can capture at that time, March, April 2020, New York First Presbyterian Hospital, Cornell, 30% of the false negative. We define false negative as the patient take the PCR test negative, and within 2 days the patient came back and the result turns positive. Then we say the first test, the first negative is probably a false negative. And this is a typical example where the result is negative, but our model predicts that there's a 0.95 probability that it's going to be positive. And these are kind of like we use something called SHAP to explain why it has such a high probability of predicting this guy as a positive, like the high CRP, and also like these inflammatory markers like ferritin and LDH, and this patient is older, and also like this lymphocyte basophil, these things are high. All these are factors that's suggesting there might be a SARS-CoV-2 infection there. So actually, when we check the EHR records of this patient, he or she came back within 2 days and result turns positive. So this is just one example of showing how do we do a risk prediction and how this can help with the clinicians. Of course, in this context, is COVID-19, and our paper got a lot of attention from different media, and this is just one example. And then the second work I want to introduce is really this causal inference. But as I said, it's really how, because in the EHRs, I mean, prediction is one type of setup. Another setup is we really want to derive some comparative insights to see, let's say, a treatment effect or some risk, but you really want to derive such risk based on fair comparisons. For example, you don't want to say some risk is higher, but your target group is like above 50 and your comparative group is below 20, right? So I mean, but EHR is never that clean and never that simple. It has complicated confounding issues. So how do we leverage those confounding adjustment technologies to derive insights from EHR? So this is one of our recent work. I think a lot of you have heard of this NIH initiative about RECOVER. So this really aims at studying the post-acute SARS-CoV-2 infection sequelae of COVID-19 patients. And I think NIH founded, I think, 3 consortiums nationally, and we are lucky to lead one of them. And my team is actually in charge of the analytics on the EHRs. I mean, the EHR initiative on the RECOVER. Analytics part of our initiative. So here, I mean, this is really, we want to compare, like, first, this is a definition when we say post-acute infection, what does that mean? So let's say this is your COVID onset. And within 30 days after the COVID onset, we call this acute period. And after 30 days, and in our case, we look at until 180, so 6 months after that, this 1 month to 6 months after the COVID onset to be the post-acute period. And we really want to compare. So for patients with and without COVID, is there any, in this case, we just look at the new incidence of diagnosis. So in other words, is there any new diagnosis appear in this post-acute period for COVID-19 patients compared to COVID-19 negative patients, right? In terms of the, we compare like the hazard ratio and also the excess burden. And we have 2 large regional clinical research networks to study this topic. So Inside is a clinical research network in New York City area, and One Florida Plus is a clinical research network, covers Florida, Alabama, and Georgia area. So we kind of like using Insight as a development cohort and try to validate our discoveries in the Florida cohorts. I mean, these 2 clinical research networks are interesting because they are also representative of the different waves with the different characteristics of the COVID-19. And so, of course, I didn't mention, so we use like 7 days to 3 years prior to the COVID onset as a baseline period to collect all kinds of confoundings, including the demographics, the medical utilizations, and the comorbidities in terms of the Alec Hauser groups and some of the drugs like steroids and I think there's another drug that used to treat the patient in acute period, and the medical utilization in a acute period, like hospitalization and ICU admission, mechanical ventilation are also used to adjust as a potential confoundings to be adjusted. This is actually our result on the Insight data. So we can see this is adjusted hazard ratio, and we have the COVID positive on the numerator and COVID negative on the denominator. So any hazard ratio larger than 1 indicates this is there is a higher risk for this particular diagnosis to appear as a new diagnosis in the post-acute period compared to the negatives. So you can see the ones with a higher hazard ratio, like these, the respiratory symptoms ones, which is not surprising. And something interesting also, you can see the hair loss and a skin ulcer, and there are also some circulatory or cardiovascular events. We also see reports from all different places. And this guy U99, UO99, and B948. So these are actually the codes defined by WHO to capture, particularly encode past. So they got, number one, much less adoption. So clinicians just beginning to use these codes. And number two is, I mean, these codes only appear in patients who have typical post-acute sequelae. So that's why you see, I mean, this code has a really high hazard ratio, which is not surprising. And these are a set of drugs that with a higher hazard ratio. So as you can see, so this post-acute sequelae is really heterogeneous and you know, not just a single symptom. It captures, or it covers a lot of a diverse set of organ systems of the human body. And this is kind of like the excess burden. So it is measured by with every 1,000 patients, the number indicates so how much more you see this diagnosis appear as a new incidence in the post-acute period of COVID positive patient compared to COVID negative patients. So you see like this is the overall, and we also stratify them according to the different criteria, like inpatient, outpatient. You can see the inpatient, they associated with darker color and the higher number, which is not surprising because I mean, inpatient, outpatient is so with respect to the utilization in acute period, because the patient who are hospitalized, they are sicker and could be potentially associated with more and more severe sequelae. And older patient is more risky. And if you look at the rows, like these long symptoms like dyspnea and lower respiratory disease, this is really long fibrosis. Actually, you observe darker colors, and also some cardiovascular conditions, you observe darker colors. And so that's another example. So certainly this is just an application of these compounding adjustment. I mean, we didn't use anything fancy, so we just used regularized lattice regression. It can achieve a pretty good performance, but certainly there could be other utilities of this kind of pipeline, like a lot of people doing trial emulation to try to find some signals either for effectiveness or safety for certain drugs. You can use the same pipeline to get these kind of analysis. And the third example I want to show is disease subphenotyping. So by the way, I think this work we if you're interested, I think I put it. I'm sorry, I forgot to put the reference here, but it is on medRxiv and currently under review by Nature Communications. But it has already been, after we got it on medRxiv, it has already been reported by some media. So if you're interested, you can reach out to me. I can send you the link. And another thing we're interested in is because all of these diseases are heterogeneous, including PASC. So the acute SARS-CoV-2 infection sequelae, as you can see, it is also pretty heterogeneous. And so far there have already been a lot of studies like what I just showed. So investigating those conditions one by one, but it is not clear if these conditions are just appearing in a one-by-one fashion, or some of them tends to co-appear together, right? So that's from a methodology perspective, it's really kind of like a clustering perspective. And similarly, I think for a lot of the other diseases, I mean, these things are all kinds of like heterogeneous. So can we look at like the clinical profiles by checking the EHRs of these patients to see if we can identify some homogeneous groups, and then we can perhaps, I mean, these different groups can be suggestive of different disease mechanism behind that, so which may trigger like stratified medicine. So that's why people are interested in disease subphenotyping. So the reason why we call it subphenotyping is because the clinical data are about the phenotypes. So the first work I want to introduce is, we published last year when we studied COVID by my excellent postdoc, Chang Su, who is currently at assistant professor at Temple. So what we are doing is still leveraging the insight data. I think this is from March 2020 to June 2020. So we want to look at if there are certain subphenotypes for COVID-19. So we really look at the time when the patient was confirmed with the COVID-19, so when they got the PCR test positive. So around that time, is there any heterogeneities or patterns of those patients, and of course, what patterns, right? So we at that time we believe like the lab tests are more indicative of the biological status of those patients. So we use, I think we picked by working with the clinician, we picked like 38 different lab tests, and then we constructed lab test profiles like what I showed in the predictive modeling example, and then we do clustering on those profiles, and we to guarantee that our process, our discovery is not by chance. So we did a complicated internal and external validation process, and actually we identified 4 consistent subphenotypes. So there is no surprising, there is a mild one, which is a phenotype 1. There is a severe one, which is a phenotype 4. But there are also 2 moderate ones. And these short diagram shows you like in terms of the abnormalities of the biomarkers, that's the lab test. So what are the characteristics of these 4 subphenotypes you can see. So one is the link is very scarce. 4, you see very dense, but for 2 and 3, you can clearly see like for 2, you see more inflammation abnormalities, but you don't see that in 3. So it's like from at least from the abnormality of lab tests, it seems that 2 was suffers from more inflammation compared to 3. But if you further look at the baseline comorbidities, you can see so 3 have more comorbidity burdens compared to 2. So if you actually check the demographics, actually 2 was younger than 3. So which means that there are also 2 moderate subphenotypes. So 1 is younger, but suffer from more inflammation in the acute phase. And there's another one, the patient are older, but suffer from more comorbidities. So these 4 subphenotypes, if you remember, so when people talk about the treatment for COVID-19 patients, there are lots of back and forth and also evidence, trials, whatever. So, this drug can work, that drug cannot work, these kind of things. So this is because COVID-19 is also a heterogeneous disease. So these kind of like stratifications can help us to understand the heterogeneity and hopefully can inform better treatment decisions and plans. And second work is also on this past, post-acute infectious E. coli. We also did something similar. So we still look at, I have the reference provided here. This is led by also my excellent postdoc. And this paper was also reported by Fortune and currently under review by Nature Medicine. And so what we do is, so we first also, if you remember my setup for the post-acute period, I also look at, and for every patient within that post-acute period, so which diagnosis is a new diagnosis. So you can see overall, we look at 137 different diagnosis categories. And if for one patient, every patient, it's a 137 dimensional binary vector. So if a diagnosis category appears as a new, then you have a 1, otherwise you have a 0. So every patient is becoming to that binary, high dimensional binary vector. We want to, if you remember the purpose is we want to see if there are subtypes. Subphenotypes means that patient groups, such that the patient within the same group, they have like similar patterns on the new incidence of these PASC diagnosis categories, right? So you can think of, oh, so a binary vector, high dimensional and do clustering. So one straightforward way would be do like latent class analysis or hierarchical clustering, but based on, for example, Hamming distance. But actually we tried, you can find nothing. You just can, when you do, after you do the clustering, you embed them in using UMAP or t-SNE. So you just see a huge cloud. You cannot really see like these clusters. Why is that? It's because for those 137 conditions, so it's not every single one of them gonna appear in certain patterns. So a lot of these conditions, they appear not very frequently, but really in sort of like a random manner. So these signals really buried the overall signals about the patterns. So what we do is we leverage something called topic modeling, which has shown superior performance in these kind of discrete count or binary type of data, but really in massive documents. They show, pretty well performance. So we in other words, we first identify a set of topics from those 137 diagnosis categories, and then we map these 137 dimensional representations to, in this case, we identified 10 topics to the 10 dimensional topic space, and the values on each topic indicates the proportion of the patient of having this topic. And then we do clustering on top of these topic proportion representations. And we actually identified 4 subphenotypes, which is very interesting. And these are kind of like the typical topics. We show it as a heat map. So these are kind of like the 137 diagnosis categories, and you can see, so there are 106 got compressed because they really have low probability of appearing in every topic. But for those topics, you can see some of the topics are really pure, like this topics really include the patients of musculoskeletal, and this one is really digestive. And then what is this? I think 5 is really nerves and so on and so forth. And some of them are mixed. And but more interestingly, so for the subphenotypes we identified, so one is cardiac and renal. So you see, this pie chart in the middle shows the proportion of the different topics where we highlight the 3 dominant ones, aggregate the rest of the topics. And this outer circle, this is circus plot, highlights the individual diagnoses that are more prevalent in this particular subphenotype. So you see, it's a subphenotype 1, you have more highlighted bars, which means that they have a more new incident diagnosis. And it turns out that this subphenotype is more severe and patients older. And also a lot of the patients got their COVID-19 confirmed during the first wave, which is March to June 2020. So if you remember, the first wave, the patients are associated with more severe clinical outcomes. And subphenotype 2 was more common one. By common, I mean it's really dominated by respiratory problems, plus some sleep and mood problems. And these patients are younger. And there are also 2 moderate size subphenotypes. So one is musculoskeletal and nerves, which is not surprising because we hear a lot of studies about the brain fog, let's say, the cognition declines, musculoskeletal pain, headache, these kind of things. But actually, when we tease out subphenotype 4, our clinicians were a little bit surprised because we don't see too much report when we did this work about digestive problems or gastrointestinal problems. But after our manuscript was released, actually there is a paper on CellMed, I think probably 3 weeks ago, and JAMA actually have a particular perspective discuss about their discovery. So what they discovered is from Europe, is from a set of COVID patients. They check their stool samples, and they find that the SARS-CoV-2 virus can stay in stool samples for as long as 7 months. So that means that even after, because this virus stay in your lung, and after a while the virus is gone. So even after your lung is cleared, the virus can still stay in your intestine for a very long time. So that's why a lot of people are reporting digestive and GI problems. So actually it is also reflected in our data, which is super interesting. And we developed these subphenotypes from inside, and which are perfectly replicated in the Florida data. So which shows that these subphenotypes are really robust. And this is, I don't, for the sake of time, I don't want to explain this in detail. But another work I want to show you is a longitudinal subphenotyping. The subphenotyping work I showed in the previous two examples is really static. So you just look at the patient records up to or at a specific time point, and then you form a vector representation, and then you do some machine learning or computation to discover the clusters. But a lot of the times, let's say for a lot of the trials, at the time of randomization, all the patients look the same, but after the patient are recruited into the trial, so their biomarkers, changes in the very different speed. So like Alzheimer's disease, there are fast decliners. So we're essentially, none of the drugs going to be effective. So which means that there are also progression heterogeneities of the patient. So that's why we are also interested in like looking at the progression trajectories of the patients. If there are some patients that can form subphenotypes, such that the patient within the same subphenotype, they follow similar progression trajectories. So this is kind of like one of the work we have done. We look at the patient who progressed from mild cognitive impairment to Alzheimer's disease. So all patients started from MCI and progressed to AD. So this is a clear starting and end point. And then we look at the trajectory. So what is the trajectory? Because from the EHR, you can get a visit by visit sequence for every patient. So you can think of if every visit you have a high dimensional event space, diagnosis, medications, procedures, then you have a vector sequence essentially, and over the time you form a sequence. But of course that sequence is high dimensional, sparse, and heterogeneous in terms of value. So we first use topic modeling to reduce the dimensionality, and then we do trajectory clustering using this latent class analysis type of method, and to identify the clusters. And so these are kinds of like the topics which I don't want to introduce in detail, but these are kind of like the 5 subphenotypes we identified, and these curves are essentially over time. So how the patient within each subphenotype changes with, in this case, will be more you can think of as a comorbidity burden. So subphenotype 1, over the time, you can see like the brain problems, and also the dementia stays at a high level, or cognition problem, not necessarily Alzheimer's or MCI, but dementia-related diagnosis stays at a high level, and the brain problems increase pretty fast in this, but others you don't really see any trends. And for subphenotype 2 is really you see there's a kidney problem, there's urinary system problem, and diabetes, metabolic conditions maintains at a high level. And subphenotype 3, you see a cardio problems and heart problems stand out. And subphenotype 4 is bone, you see movement. And subphenotype 5, you see these eye problems and mental health problems and so on and so forth. So you really can tease out like these different trends. In terms of the increased burden of the comorbidities in this case, that could be indicative of a different mechanism, or like even, when we talk to our neurologists, may even, because we know like this Alzheimer's disease is highly difficult to diagnose, it may also indicate some misdiagnosis. She particularly pointed out this bone and movement problem. It could be some Parkinson's related or movement disorder related dementia rather than exactly Alzheimer's disease and so on and so forth. So this is although we have posted this manuscript on medRxiv long time ago, but we're still working on this. Is collaborating with UCSF to try to and many other institutions, Mount Sinai, Florida, Kentucky. Trying to do more on the clinical interpretation side. And last, maybe I just need 3 more minutes to finish this. And at last, so what I showed is really our work on electronic health records, but certainly I think people are wondering, so what? So you built these predictive models, you discovered these risks, you identified those phenotypes. So what? So what we can do next? So certainly one of the things we're interested in is from these phenotypical manifestations, can we trace back to their potential disease mechanism? But certainly if you have, you're lucky, you have the link, the genomic data, like in this case, in Parkinson's case. Oh, I'm sorry, I think I copy pasted the wrong reference here, but if you're interested, send me an email. I will send you the paper. But this is also something we posted on medRxiv. So essentially, we identified progression subphenotypes from Parkinson's disease patients, but we also have the linked sequencing and the neuroimage data for these patients. So after you identify these subphenotypes, you can do, we identified 3, like mild, fast, and moderate progression. You can, using those comprehensive features, do the analysis of different subphenotypes. And in this case, we also look at if we can predict these subphenotypes at early stage. Of course, you have the genetics. You can also do differential gene expression analysis to see if there are different risk genes for different subphenotypes. So, for example, what are the genes that could cause more likely to cause a rapid progressing Parkinson's disease or no? But most of the time, we don't have the luxury of having this linked database. So one way is, so because these electronic health records are all on the phenotypic side, so we have these diseases, symptoms, and drugs. So using this knowledge graph, so we can map them back to their potential pathways or genetic origins to, or even you can look at the potential drugs that could be linked to your particular phenotype pattern to enhance your knowledge about these phenotypic heterogeneity. And we have built this, we call this integrative biomedical knowledge hub. We integrate, I think now we integrated 18 different biomedical knowledge sources, but we're still in the process of integrating more. And we also made a graphical interface. You can do queries, you can do, we also implemented some of the deep learning based knowledge inference algorithms on top of that, so you can do link prediction and do inference if you're interested. And this is currently in beta version. If you're interested, send me an email, I can send you the link, you can play with it. I think that's all I want to talk about today. And I just want to say, in addition to electronic health records, so there are lots of other ongoing activities in my lab and touches all these different kinds of data types. Certainly we are lucky to be able to collaborate with a lot of excellent institutions on all this work. And my goal is really to integratively analyze all these kinds of biomedical data to derive insights for the diseases. And this is the acknowledgement, grants, industry donations, and members in my lab. And we are always interested in working with excellent researchers. If you're interested in doing research with me, feel free to reach out. And this is my contact information. And thank you very much.
Cool. Thank you, Professor. That was an absolutely fascinating talk, and we have some questions from the audience. So back in the causal example you gave and the one after, I think there were some questions. There were some technical detail questions. I'll just let them reach out to you for the papers or manuscripts for that, if that's okay.
Sure, definitely.
And there was also some questions relating against like, did you consider confounders, and how was the effect different for like vaccination and for age? Like, what does that stratification look like? And because we're sure that this is probably not just an overall blanket statement about risk.
Yeah, I think that's a good question. So as I explained, so this is the first batch of work that comes out with this recovery initiative, and as I said, so we only consider new incidents, and actually, if you talk about past, there could also be exacerbation and prolonged conditions that we are currently investigating, and certainly reinfection and vaccination is one important factor we are currently working on. And the challenge for vaccination is those vaccination records in EHR is never complete. So we have to link with state registry. So there are some logistic work there, but that's one of our current ongoing efforts. Yeah.
Cool, that's really cool. And then there was another question about like what type of coding systems do you guys use, and another question about EHR systems in general. So I think those go together pretty well. There's questions about like, do you use ICD-9, ICD-10, SNOMED, NDC codes, or some other coding system? And then also a general question about the future, like how you view EHR systems and the future of them, because there seems to be a lot of, well, to quote, more complaints than compliments from the provider side.
Yeah. I think let me answer one by one. Okay.
Yes.
So in terms of programming, right? So because all my team members are from computer science, so we pretty much use Python. But for some of the statistics procedure, like calculating p-values and those conventional statistics model, we also embed in some R code there as well. And for the EHR system. I forgot. I mean, but for the EHR system question, people always complaining, right? So it's not easy to get people buying, these kind of especially digital technique, especially for clinicians. But one thing we have to admit is that they really capture a lot of useful information, and like Epic now is kind of like the dominant player, and they are they have continuing efforts to improve their system, and also capture currently we talk more and more about SDOH, social determinants of health, and they are trying to capture those information as well, and they are also working on capturing other information, and there are also a lot of efforts on how to improve the quality of the information, and so on and so forth. And with like these other initiatives, like All of Us, and especially in last year, early this year, NIH had those initiatives about like AIMA had, Bridge to AI. All of these emphasizes open science and sharing data. So with these more, I wouldn't say auditing, but with more eyes, the quality is going to get better and better. And there are also people working on particularly deriving algorithms to improve data quality as well. So it's definitely getting better and better.
Cool, thanks. My next question is that Dr. Yeli is asking, he says, thank you for the great talk, first of all, and then for the DynaPhenom framework, or how were the inputs to the dynamic multimodal topic model, and how do we deal with irregular time intervals in outpatient data? I think this
I didn't get a chance to talk about the details. Really, as you can see, so we chunk the timestamp into, I think, quarter by quarter. So now it's regular interval. We aggregate every 3 months into a vector. And in terms of the temporality, so we inject a transition matrix from states to state. And we learned that, I don't have that slides, but we did show also what the transition matrix looks like. So that encodes the temporal dimension. Yeah.
I see. Thanks for yeah. So actually, I'm on the call. So like for that question, so do you use all patient data, or like usually all patient is very irregular, right? So
yeah, I think we didn't. I don't think we really discriminate like just to use outpatient or just to use inpatient. Really, it's whatever in the EHR system. We just aggregate all of them.
Yes.
And then there's another question from Jian Zhu, and we know that, well, he says, first of all, thanks for the great presentation. And we know that like missing data has always been an issue that's plaguing the data science community. So it's a question on missing records or missing data in general, wondering if you could share some experience, suggestions.
Yeah, I think this is a really good question. I think I got asked every time when my paper was sent out for review. So I think personally, imputation is important for sure, but I'm not a fan of fancy imputation technologies because you know you can make however you want. I mean, complicated like deep learning models to do the imputation and you get good performance, but it's hard to justify the generalizability. You know, imputation, the values are really from guessing. So better performance, you know, from better imputation method, it's hard to tell. It's really from the data or you just guess it better. So I mean, for me, I typically just use more conventional, well accepted like multiple imputation or mice, you know, with chain equations, these kind of things, to do the standard imputation. And typically those you know methods would suffice. Yeah.
Okay, cool. And then the last question, I guess I have a personal question as well, is that from the application perspective, like, can you share a little bit of your experience about how receptive practices and I don't know, policy are to these more complex statistical technical type of models for healthcare in general, for the COVID work you've done and also beyond?
Yeah. I mean, that's a good question. And I have to admit that's one advantage for me to work in the medical school, because I never do these technical work alone. So as you can see from the authors, so there are always a group of clinicians working with us. So I think from my experience, you don't want to work alone for these medical analysis of problems. It's always a good idea to have a domain expert, either clinician or a biologist, depends on what kind of problem you're working on, to regularly, you know, communicate with them and to make sure what you work out makes sense, and get feedbacks in time. I think this can, number one, makes what you have done much more impactful later on, and also make sure that you don't really do something by hypothesis, but it's really useful.
Mm-hmm. Yeah, there's been a lot of real world data that's been like the emerging trend in a lot of these analyses. So do you see that the like working with maybe the FDA or working with other
Yes.
regulatory agencies, like have they been really receptive to that, or have there been like barriers, roadblocks in the way?
I think certainly you can see the plausibility there, right? So FDA continuously push out this kind, you know, this white paper or that white paper, or, you know, call for comments, these kind of thing, right? So certainly people are thinking of that, and I think you know, interacting with regulatory agencies like FDA can, I think, similarly as working with clinicians, so can get you know, you the knowledge about what these policy makers are thinking about, and I think you can just make your work more solid. Yeah.
Okay, cool. And then we have another question that popped up for adjusted hazard ratios. How do you adjust propensity scores for each?
Yeah, that's just a propensity. That's actually very interesting. If you're interested, you can send me email. I will send you. We have another paper that is you know, currently under revision by Nature Communications. So it's you know, because it's EHR, so people think about there are different ways of calculating the propensity score because of its complexity. But we actually find out I mean, deep learning or complex models not necessarily outperform simple lattice regression. I mean, but this model selection plays a very important role there. I mean, if you send me an email, I mean, I can send you the reference and we can discuss.
Awesome. Yeah, completely agree. It's all about using a right method, not using the fanciest one. Anyways, this concludes our Q&A session and also our talk. Thank you so much for having this talk with us. I think we've learned so much in terms of methodology, ideas, the general landscape of things. And thank you to the audience as well for being so thoughtful in these questions and just being so engaged. Yeah, I think we can end the recording here. And thanks for coming to this talk, and we hope to see you at the next one.
Thank you. Bye-bye.
Everyone.